Up next, we have Dr. Scott Kirkley. Dr. Kirkley was born and raised in Poplar Bluff, Missouri. He attended Southeast Missouri State University in Cape Girardeau for his undergraduate degree. He attended medical school and residency in internal medicine at University of Missouri in Columbia. Dr. Kirkley is licensed and board certified in internal medicine. He has been employed with BJC Medical Group at Parkland Health Center since 2007.
Hi, I'm so honored to be here tonight. My position, I think, on this panel is to provide some education about what we can currently do for those people who are currently dealing with addiction as a main part of their disease. Next slide. So, and I think as we started off tonight, we got some idea about what opioids are. In essence, opioids are a broad group of pain-relieving drugs. They work on a very specific receptor in the brain. It's called the mu receptor, and it's synthesized from the poppy plant or synthesized in a lab, as already mentioned. I have at the bottom kind of a list of some of the more common ones we've seen, and many of them have been mentioned already tonight, but the one at the end of this is one that commonly gets overseen, and that tramadol itself is an opioid, but it's a very common drug that people use. This, I think, is probably one of those slides that I've given about 12 talks about opioids, addiction and management, and how to start a clinic and how to treat people over the last 6 months. And so every time I see this slide, I think about leaving it out because I feel like I've talked about it so much that everybody already knows this. But this is one of the more common things that I think people misunderstand about addiction itself. We tend to group all forms of opioid use into this general category of addiction. And as I point out here, addiction is a very complex condition. It is a brain disease. It's manifested by compulsive actions that, despite harmful consequences, people tend to repeat. It's driven usually by people who, once they've taken an opiate, they get a sense of euphoria. And if you've talked to people who have this certain kind of brain chemistry, and it's estimated that about 5% of the population has this, the sensations they get from using an opiate cannot be mimicked by anything else they've ever experienced. It's better than sex, it's better than winning the lottery, it's better than anything we could possibly imagine. The parts that have already been hit on too, the bottom one is the dependence. This is what we were talking about, where somebody uses a medication. Once they've used the medication, they try to stop it and they withdraw. They have symptoms of withdrawal, which then makes them dependent on the drug to stop those symptoms. And as already mentioned, that does drive people to switch from using prescription drugs, which they're no longer going to be prescribed because doctors are getting better at cutting off people who have been on pain medication, who don't need to continue long-term pain medication, as well as people who are buying it off the streets but finding cheaper versions and the more toxic stuff that's currently being laced, like heroin, and fentanyl is, I agree, a very nasty drug all around. And then the other one, I'm sorry, go back one more. The tolerance, and this is the part that people don't see a lot. These are the people that are taking pain medication with or without a proper explanation for it, who after a certain time, the pain medication doesn't relieve the pain the same way. Or if they are getting the euphoria from it, they're no longer getting the same euphoric feelings, and so they have to start upping the amount. This is dangerous in some of the categories where we see somebody who has, say, been an opiate user who goes to prison or is removed from that in some other way. And for a certain amount of time, they're no longer exposed. They had a very high tolerance when they went in or when they were removed from it. When they come back and they start using again, they think, well, the last time I shot this much heroin, and the first time they do it, they overdose and they die because their tolerance is no longer there. Next slide. I think, as we've kind of already talked about, intervention for this can be very successful. It involves education, it involves harm reduction, but I think that as we work through this, the big part is kind of changing the perception of what we're dealing with. And we have to start understanding addiction as a disease, not as a just personal choice that's meant to ruin somebody's life. I tell people all the time, very few people wake up one day and they think, I wonder what the quickest way to ruin my life is. Heroin? Let's try that. Nobody really does that. So if we start looking at this as a disease, it's a little easier to kind of pull back how we feel personally about it and start treating it. Because I've never been upset when somebody with high blood pressure or diabetes comes in and told me they ate chocolate cake or salt. Next slide. Oh, wow, that's really small. Okay, the nice thing is that the only part of this that I think is really important, no, I'm just kidding. When we're treating addiction, this is usually a multifactorial kind of thing, and I think, again, we're trying to see that theme tonight. Counseling is absolutely necessary for people that are dealing with addiction as a disease. Most people lack coping skills. It's just that most people don't tend to cope by using drugs. And so anybody who's dealt with addiction as a disease, when they tend to run into problems, and sometimes not even problems, when good things happen, they don't know how to cope with them, they tend to turn back to the thing they've always enjoyed or the thing that's always helped remove the psychological or physical pain they're dealing with. So counseling has to be part of this because people have to learn to cope. The second part of this, the medical assisted therapy, I will get into in just a minute. And then the last part is a community program called Communities That Care. A lot of these kinds of programs are popping up everywhere. There are links to this if anybody ever wants to see this. If anybody asked for this presentation, you can absolutely have it. On the very bottom of this was a New York Times opioid crisis solutions, where they asked a bunch of people who are deeply in the opioid crisis. They asked DEA agents, and they asked doctors, and they asked social workers, and they asked community leaders. If they were given a certain amount of money to combat this, where would you spend your money? It's fascinating to see where people would spend the money. As doctors, we tend to think that all the money should be put into medication. And there's actually good reason for that. Not that the other stuff, again, doesn't matter. But there is good reason for that. Next slide. So this is the big part of what I do, medical assisted therapy. It's commonly known as MAT. That's how it tends to be referred to. And there are several medications that we tend to use for this. The one that is the old tried and true is methadone. Methadone is a synthetic opioid that was developed. It is extremely powerful. When methadone clinics came about, and still are actually, I guess, they're very highly regulated. Methadone is very addictive, and it was primarily used to treat people who were heroin addicts who had developed a very high tolerance to opioids. They just didn't find something strong enough to be able to treat those people. They would withdraw on the other opioids, so they started making methadone and using it at high enough doses to be able to treat the withdrawal for people. Methadone clinics still exist. They, again, are very highly regulated, meaning most people that are in a methadone clinic have to come and get their methadone on a daily basis. They literally have to show up to the clinic every single day to get their dosing. After a certain amount of time, they are allowed a grace period where they can go home with a, quote, take-home amount, which is usually about a month's worth of the methadone. But that usually involves at least a year or two of them being very stable in the methadone clinic. Suboxone and Subutex is where I primarily work. Naltrexone is akin to Narcan. I don't know if anybody's ever seen or heard of this, but naltrexone has been primarily studied in alcohol addiction. It seems to be very, very good with this, but studies have actually suggested that long-term long-term opiate relapse rates are the same with naltrexone as it is with Suboxone. And then clonidine is one that we are seeing more often, but it's used to treat more addiction or more acute withdrawal in patients as opposed to long-term therapy. Next slide. Oh, I did talk about some of this. Naltrexone, like I said, is something it works like Narcan. It blocks the euphoric effects, and it is not displaced by other opioids. If you have it on board, you can't get high on it. But it does seem to affect the cravings that people seem to have for this. Next slide. All right, that's really small too. Okay, let me see if I can kind of sum up here. So Suboxone or Subutex, the drugs have been around actually for about 20 years. Suboxone itself is actually generic at this point. As an opioid, Suboxone is unique. The drug name itself is buprenorphine. Buprenorphine has a very high affinity for the opioid receptor, meaning that when you take buprenorphine, if you have other narcotics in your system, it will absolutely displace them all. It will come in and it will kick them out. And some of the problems that you see, or some of the, I don't say the problems actually, because I'm not sure if it's ever been proven, but some of the risk with buprenorphine is that if somebody has recently used and they take buprenorphine, that you could put them instantly into withdrawal because it's not actually as stimulating as at the receptor as a lot of the other narcotics are. Because of its affinity for the receptor, though, if you are taking buprenorphine and you try to use other opiates, you actually cannot get high off of it. It also has a very slow dissociation rate from the receptor, meaning that once you've taken it, it sits there forever. So it does its job for a very long period of time. With my patients that I work with this kind of medication, most of them will take the buprenorphine several times a day. And more of that's a psychological effect of wanting to take something more often because that's usually how they were taking the opiates before. But because this has more than a 24-hour life to it, technically, as long as the dose is small enough, you can take it once a day. The buprenorphine also has what we call a ceiling effect, meaning that when you take the medication, you can't, if you try to overdose on it, the drug does not become effective at doses higher than 24 milligrams a day. You can't overdose on it. It doesn't cause the respiratory suppression because it doesn't stimulate the receptors that a lot of the opiates as strongly as the other opiates do. And while I'm not an addiction specialist, and I've talked to more than a few people that have prescribed Suboxone, there is some disagreement about this. I am pretty sure you cannot kill yourself with Suboxone. Next slide. Currently, every physician in the United States that holds an active DEA license and all mid-level providers, nurse practitioners, and physician's assistants are eligible to get the waiver to prescribe Suboxone. I appreciate the fact that they allow people the opportunity to go and get education for this. But since you can't kill people with Suboxone, I think that the waiver program should absolutely go away and anybody with an active DEA license should be able to prescribe. As part of the presentations that I give, I typically talk about some of the history of opioids and what we call scheduling of opioids. So when drugs in the United States are classified, they're classified into one of 5 classes. Schedule I drugs are drugs that have been deemed to have no medical value. So heroin, methamphetamine, technically cocaine is in there, but is a level 1 narcotic, or is a Schedule I drug. Schedule II drugs are the really, really powerful ones that you have to be very concerned about. These are the oxycodones and the stronger opioids, including hydrocodone, which is more common. Schedule IIIs are things like Tylenol 3, but this is where Suboxone fits in. It's actually a Schedule III drug. Schedule IVs are non-narcotic drugs that are controlled like Lyrica, and Schedule Vs are basically blood pressure medicines. Next slide. So my experience for this has been the last 3.5 years I've been prescribing Suboxone, and there are a few things that I kind of take away from this, and I try to encourage people to think about. Now, I will tell you that I give this presentation to other providers in hopes of inspiring them and encouraging them to go out and get a waiver and start treating addiction because it's such a need. But I think that this kind of applies for everybody. You know, I think that we've already hit on this and that, you know, we can't really treat people as addicts. We can't label them. We don't label the diseases. We don't tend to be so down on every other disease that affects people's lives the way that we are down on people that are suffering with addiction. And while I know this is primarily about opiates, I would say that any addiction probably deserves that same common courtesy as a human being. Personally, it took me years to get here. When I first started my program, everybody had 6 months to get through it. They would come in, I would put them on Suboxone, and I would titrate their Suboxone down within 6 months. That was the rule. And I'm pretty sure nobody completed that program. And then after I realized that people were just using drugs again and I was not helping them, I said, okay, well, maybe it shouldn't be 6 months, but everybody has to get off Suboxone. And nobody completed that program either. And at this point, I think that my treatment of patients is that they have a tendency to get to control how we treat their addiction. I don't come in and tell them what we're doing. I ask them how they're doing. I ensure that they're working with counselors. I ensure they're doing what they should be doing. But the big part of this is number 5. And it's like, it's really not about you. It has to be about them, and it has to be there all the time. Next slide. There has been some of this thought about how to really kind of fight this. I believe that, you know, doctors are getting the idea that they're prescribing too many narcotics, and they've kind of stopped doing that. The federal government is getting some really stupid ideas, like just flat out saying you have to produce 50% less narcotics, and that pharmacies will now have caps on how many narcotics they can give out per month. I believe these things are really, really irresponsible, and as has already been touched on, those people will start using heroin. It is very cheap, and it is very available to everybody. So we need to be careful about how we do this, but some of the more or some of the better thinkers about this have developed some of this stuff. Number 3 has already been talked about, right? This is something that everybody should be walking around with. If you know somebody who owns a narcotic, who takes a narcotic, whether it's as needed or it's all the time, there should be Narcan. They should go together. I think that number 2 has been pointed out as well. You know, we need to aggressively treat people who go to prison. A lot of people in prison have problems with opiates, and they need to be treated not just when they get out, but during their stint in prison to help control the addiction so they have a better chance when they get out to maintain that sobriety. Drug checking services. Nobody's touched on this yet, but you know, the concept that you could take your illegal drugs and walk into a police station and have somebody actually check this for fentanyl before you take it and die is way outside the box, but would absolutely result in harm reduction if we could convince people that we will in some way decriminalize a lot of what we're seeing here. Drug take-back programs. A lot of people have a lot of opioids sitting around they just simply don't need, and those drugs typically find a way to find somebody who will be willing to use them. Drug monitoring programs. Number 7 is something that Missouri is the only state in the entire United States that does not have a prescription drug monitoring program, except for St. Louis County decided to just start their own because the state wouldn't. It is growing, and it now covers about 85% of all Missourians, but it allows doctors to actually get online and see what somebody's been prescribed as a narcotic. So if I'm sitting there and somebody says, I need this for my pain, and I believe the pain is something that would require a narcotic, I can get online and look to see if they've actually been prescribed. Are they doctor shopping? Are they pharmacy shopping? What are they filling and when are they filling? I would hope that at the times when those things are identified, people will not treat them again as addicts, but try to encourage them to treat the addiction itself as a disease, engage them in what they're missing. Drug use centers. This is something that gained some popularity in Canada. This is the idea that you could come to a place and shoot your heroin where there are medical professionals sitting around with Narcan simply to bring you back without arresting you. And then I'm like number 4, but I know that people know that that's probably the hardest one ever to get rid of. So next slide. Oh, great. My time is done. Thank you all. Again, I'm going to leave here with 2 Narcan if I can, just so everybody knows. I think everybody should.